in our department. Okay, so I'm going to start off by saying that we are known as nuclear medicine and not radionuclear, has commonly been referred as. Okay, so we are a department by ourselves and we do not come under the wing of radiology. So nuclear medicine is actually a field of theranostic, whereby we actually use a radioactive material to do a physiological imaging as well as therapy for both the malignant and non-malignant lesions. Okay, so this nuclear medicine, so this nuclear medicine, it has been established very long back in the 60s. So initially it was established at Hospital Kuala Lumpur under the wing of oncology and radiotherapy. So as the time passes, it was actually under medical department in way 1980s before it fully emerged on its own. So now that based on KKM Hospital, we have 6 hospitals and it's located at South Malaysia at Hospital Sultanah Aminah, centrally located at HKL and IKN, and in the North Malaysia, it's located at Hospital Pulau Pinang. And of course, on this side, on our side, we have it one at Sarawak and one at Sabah. So beside the hospital-based, KKM-based hospitals, we also have nuclear medicine services at hospital universities and also private hospitals. Now, before I go into depth, I'm just going to generally briefly describe on the radioactive substance and also the imaging tools that we use. So once we understand this, we can actually understand what is nuclear medicine is all about, right? So for us, radioactive substance is actually a very, very important source. And this source are mainly gained through either by generator, the generators, it's on your left-hand side, that this is the generator, or through cyclotron, or via nuclear reactor. For nuclear medicine at Sabah service, our functional images are mostly done by using this TC-based radioactive material. Okay, and not only in Sabah, but other centers also utilizes this generator. As for cyclotron, there's only one for a KKM-based hospital, there's only one cyclotron available, and it's located at Hospital Putrajaya. So the radioactive sources gained from the cyclotron are mainly used for the PET-CT images. So on our side, we are working really hard to have our very own cyclotron so that we can start off our PET-CT services. So it's on its upcoming project. And we also have a radioactive sources which comes from a nuclear reactor. So as for this nuclear reactor, we don't have it in Malaysia. Okay, so any medication that requires production from a nuclear medicine will be done and it will be shipped to us. So for example, like iodine 131 that's commonly used for thyroid cancer and RI therapy, it is actually generated from the nuclear reactor. Right, so what we do now that we are using a generator day in, day out, so I'm going to briefly explain how do we actually prepare the medication to be given to the patient. So what happens is that our pharmacists will be going to this generator and they will elute the radioactive material. It will be taken into a vial, okay, on an everyday basis. So once it's being taken into the vial, TC99M stands for technetium. That's the commonly used radioactive sources. So this technetium has to undergo a process what we call as tagging. Okay, so tagging means what happens is that, okay, let's say for example, I wanted to image a bone. So I need to HDP, which is a hydroxymethylene diphosphonate. When we attach this medication, what happens is it will only goes to the bone. So when we image, we only see bone structures. For another example, let's say if I were to image kidney, I need to attach the technetium with MET3. Therefore, this whole medication will only reveal kidney organs. Same goes to the heart. If I need the heart, I need to attach with tetrophosphine. And likewise, if I were to image other organs, it has to be attached to the specific pharmaceutical. So it comes in a vial like this. Okay, so attachment need to be done beforehand. So once this tagging has already been done, we will give to the patient. So the method of administrating this radiopharmaceutical can be done either intravenously, through inhalation, through topical drops, or we ask the patient to consume in the form of liquid or food, inject in the diazolate, or we can also inject subcutaneously, intradermally, subfacially, whichever required for that particular scan. Okay, so various method of administration to the patient. So once it's been given to the patient, this patient will become a radioactive source. So when this patient become a radioactive source, we will put the patient under the gamma camera. And when the technetium started to decay, it will start emitting it will start emitting gamma rays. Okay, and this gamma rays will eventually be picked up by our machine, hence an image will be formed. So far, so good. That's how we do a physiological imaging. Now, another important tool for us is our imaging machine. So for us, we use a machine, what we call as a gamma camera. So the current machine that we are having at our department is a dual head gamma camera, whereby when we image patient, we get a 2D view. For example, in this image, we have a bone scan image of anterior and also posterior. We could also do additional view by doing a lateral and also an oblique views. And we have the ability, when we rotate the camera along the patient's body, we can actually generate a 3D images. So the only limitation of having this whole image, 3D image, is known as a SPECT image. So the only limitation is that the precision of the anatomical localization and the characterizing the lesions on CT may not be available. So that's the limitation that we are having at the moment. But nevertheless, as the technology has progressing, now we have a hybrid machine. In this hybrid machine, we have a gamma camera component over here, and we also have a CT component. Hence, when we image patient, we get best of the both world. For example, and let's say I'm doing a bone scan, I'm using a nuclear medicine component, the planar imaging, to get imaging of a whole body. And now, as we can see, there is actually a focal spot in the lateral aspect of the, the lumbar vertebra. So what we can do is we can do a SPECT, hence we get a nuclear medicine functional imaging over here. Now the bottom row is we can introduce a low dose CT scan, whereby this CT scan will tell me the exact location of the lesion and the characteristic, what type of character the lesion is actually producing. Hence, when we fuse the image at the bottommost image, we are getting a SPECT CT, a complete anatomical and physiological imaging. So by having this modality, there's two things that I'm getting. One, I can increase the specificity in what type of lesion are we dealing with, and number two, a perfect anatomical localization. So initially, this lesion ought to be a malignant lesion, but turns out to be, when we have this combination of this image, turns out to be a sclerotic lesion at the facet joint L5. So this is a degenerative process. So obviously the management is going to change if it's just a degenerative changes. Okay. Now, having said, giving a brief introduction on the machines and how we do the imaging, now I'm going to talk briefly on the services available at Hospital Wanita and Kanak-Kanak Sabah. So the first one would be the bone scan, right? So the bone scan for the indication, we can use bone scan to assess metastatic lesion, whether there's a metastatic lesion presence in a patient with underlying cancers. But in order for a nuclear medicine scan, this HTP, hydroxymethylene diphosphonate, to pick up a bone lesion, it has to be tumors that produce a sclerotic lesion type. For example, like a prostate cancer, breast cancer, lung cancer, these are the lesions which produce a sclerotic type of a lesion. This sclerotic lab will be clearly and beautifully will be picked up in our scan. So in this patient, we can see an extensive metastatic involvement in almost right from the head up to the mid-femur. All right. However, there are certain tumors, like for example, like multiple myeloma, renal cell cancer, like thyroid cancer and lymphoma. These are the type of tumors which, if there's a bone involvement, it's going to cause a lytic bone lesion. So for example, let's look at this, the pelvic X-ray. So in this pelvic X-ray, we can see some translucent area in the right side of the ileum. Okay, this is producing a sclerotic lytic type of lesion. So when we do a bone scan, the bottom image there, we can barely pick up that lesion over there using a bone scan. The reason is the HTP is not avid towards any lytic lesions. So in order to assess lytic type of lesion, it would be best to be done with a F18 FDG PET scan if there's available, or else even CT scan should be able to pick it up. Okay. Next indication would be assessing primary bone tumor. For example, for instance, for this DME, I'm going to give an example of the osteosarcoma. It's a primary bone tumor. When the primary bone tumor is proven histopathologically, so what we need to do next is to estimate the extent of the tumor involvement, whether it is localized or it has a skip lesion. So doing a whole body CT scan or an X-ray may not be feasible. Hence, we can do a simple method by using a bone scan where we can actually pick up it is localized or it has already gone elsewhere in the bone. So in this case, the primary tumor is actually localized right at the distal to the mid femur, with possible one involvement at the bone involvement at the ribs possible. Okay, so these are the indication primary bone tumor assessment. Now next, we can also do a bone scan for cases of infection. For example, in this case, this is a case of a pediatric whom have been complaining of having a right knee pain for a few months. So when we do a bone scan, there is abnormal uptake of tracer can be appreciated on the right proximal to mid tibia as comparatively on the opposite limb. So by having this abnormal uptake of tracer, when it was further investigated, it was proven to be an osteomyelitis. So it also a good modality to identify sources of infection. Okay, so next indication could be we can use bone scan to assess for a fracture. But of course, fracture identification bone scan may not be the first modality to assess for fracture. Nevertheless, it can be used. So in this case, a bone scan was performed in a patient who has been complaining low back pain for a few months. And what we noted is that there is an intense uptake of a tracer with a H-shaped sign at the sacral region. So this is actually a typical features of a sacral insufficiency fracture. So these are the things that we could actually pick up on our bone scan. Next, bone scan is also a good modality to assess for a primary metabolic bone disorders. For example, Paget's disease. So the image on your left-hand side, this is actually a typical features of a Paget's disease on a bone scan where there is a multiple bone involvement. The bone is actually expanded, very diffuse uptake of traces. Okay, it can be used in a metabolic bone disease. It can also, for another example that I can give is the fibrous dysplasia. So in this patient, he's been having a very intense uptake around the skull and also the sphenoid bone. It's a parrot wing sign and also involvement of bone on the left lower limb. So you could use to assess metabolic bone disorders. And in case if therapy has already initiated, if you wanted to have a follow-up scan, whether it's responding or not, it also can be done. Okay, next. And for some rheumatological disorder, in this case, I'm giving an example of rheumatoid arthritis, and bone scan using a 3-phase bone scan can actually tell involvement of a small joint. Okay, the first image over here, this is a blood flow followed by a blood pool. The B image is a blood pool and C would be the delayed image. So as you can see, there is an asymmetrical increased uptake of tracer in the right side of the hand, which on delayed, we can see all the joints are being taken up. So the image on your left-hand side is more typical features of a rheumatoid arthritis of a bilateral hand. So it can be used to assess for rheumatological disorders. Apart from that, we can also use a bone scan to assess for therapy responses. For example, at the time of diagnosis, this is a patient with the extensive bone involvement with an underlying prostate cancer. So after initiation of the treatment, at 3 months of the therapy, we could see some amount of improvement. And by 6 months of therapy, there is a tremendous amount of improvement. So bone scan can also be used to assess a response to therapy. Either it's responding or not responding. All right. So now, to be honest, the indication of bone scan is not only limited to what I have explained just now. There's actually a vast more indication to be done. And because the CME is limited to 1 hour, I may not be able to cover everything. Okay. So next, a thyroid scan. I'm sure you guys are pretty familiar with this thyroid scan. So thyroid scan mainly can be used to identify what are the causes of hyperthyroidism, and our thyroid scan can pick up Graves' disease. This is a very typical features of a Graves' disease. There's a diffusely increased uptake of tracer in the bilateral thyroid gland. In a case of a multinodular goiter, we can see an area of increased uptake and an area of a decreased uptake, typical features for multinodular goiter. We can also use to assess any solitary hyperfunctioning thyroid nodule. Yeah, assessment can be done. And thyroid scan can also be used to assess for presence of ectopic thyroid gland. So in the first case, you can see there is an absence of uptake in the thyroid, in the normally situated thyroid gland. Instead, we are looking at a focal increased uptake of tracer at the base of the tongue, which is an indicative of a lingual thyroid. So ectopic glands can be, we can do an imaging for that. Apart from that, congenitally, if in case there is disorders known as dyshomogenesis, we can also imply this thyroid scan. Congenital absence of thyroid gland, also we can use this modality. And apart from that, in case there is assessment for a cold nodule, yes, nuclear medicine imaging would be a good modality to assess, because when there is a cold nodule, the likelihood of getting a malignancy is about 10 to 20%. So we can guide you where exactly to put the needle for the FNAC. Okay, right, that's about thyroid scan. And now let's move on to the parathyroid scan. All right, for parathyroid scan, I'm sure you guys are pretty familiar with the parathyroid scan. So it is mainly being used to identify a presence of the parathyroid adenoma. So once it is being injected, what happens is anything that is being highlighted here, the hotspot that occurs, it is actually a hyperfunctioning parathyroid adenoma. In this case, we can identify there is actually 2, and the location would be good to identify, so it can be a minimally invasive exploration by the surgeon. So in terms of location, it's located in the lower pole of bilateral thyroid gland. And apart from that, not only that, we can also assess presence of ectopic parathyroid adenoma. So in this patient, we managed to identify an ectopic at the anterior mediastinum. The only limitation at this junction is we do not have a hybrid machine yet. If there is one at the same setting, we can do a CT scan, whereby we can identify the approximate location of the adenoma to assist for the surgery. Sometimes in a case of severe hyperparathyroidism, Brown's tumor also can be picked up. Okay, if you're lucky enough, we can actually pick up Brown's tumor on our scan. Next, gastric emptying study. So this is another modality whereby we can assess any gastric motility disorders. So I'm going to show you the normal gastric emptying study first, so that we can appreciate the abnormal ones. So in a normal gastric emptying study, what happens is we will ask the patient to consume radioactive sandwich. So we give a sandwich, we make the radioactive material inside the sandwich and ask the patient to consume. So once it is being consumed, we will image patient at 1 hour, 2 hours, 3 hours, and 4 hours. And by right, when each hour passes, the percentage of retention of the tracer will be calculated. And by right, as the time passes, the radio tracer is supposed to be moving into the bowel, and by the end of 4 hours, it has to have a very minimal tracer retention in the bowel. So this is how a normal gastric emptying study looks like. But whenever there is a motility disorder, what happens is whenever we introduce a radioactive material, it will remain in the gastric until the end of study. So when there is a remaining tracer in the stomach, then we can confirm, yes, this patient is actually having a gastroparesis. So these are one of the scans that we can do in our hospital settings. Okay, apart from that, we also do imaging for hepatobiliary system. I will be showing first the normal hepatobiliary system scan first so that we can appreciate the abnormal scan. So once we inject the radio tracer intravenously, by right, the radio tracer is supposed to accumulate in the liver. Once it moves to the liver, it will start accumulating slowly. The radio tracer will migrate into the right and left hepatic duct, and eventually it will go into the gallbladder. And the other remaining radio tracer will be excreted into the bowel. So at the end of the study, this is how the image is supposed to look like. However, in a case of acute cholecystitis, we're going to start off with acute cholecystitis first. What happens is the tracer are going to accumulate homogeneously in the liver. Eventually, it's going to be secreted into the biliary duct system and into the bowel. However, at the end of the study, we may not be able to appreciate the gallbladder. Reason being is the gallbladder is inflamed and the radio tracer cannot enter the gallbladder. But for acute cholecystitis, a nuclear medicine scan is no longer, I would say no longer, it's not commonly or routinely it's being done, because as simple as ultrasound, gallbladder can reveal the diagnosis of acute cholecystitis. And another reason why we do not do is that this imaging, in order for us to confirm presence of acute cholecystitis, the imaging has to be done up to 4 hours. So patient has to wait, which we don't encourage that. As simple as ultrasound will do. But in case in future, if you have any referrals for acute cholecystitis, I suppose it shouldn't not be a problem for us to do this imaging. All right. Apart from that, the most commonly used HIDA scan is for biliary atresia. So in a case of pediatric, whereby who's suspected to have biliary atresia, nuclear medicine imaging is the gold standard. What happens once we inject the radio tracer? There will be persistent radioactive material will be retained in the liver without excretion into the biliary duct and also the bowel. So this is a very typical features of a biliary atresia. Next, we can also use a HIDA scan for biliary leak in a case of intra-act injury or any traumas to the abdomen. And also those patients who have underwent intervention, surgical intervention, that we suspect there might be a biliary leak. So nuclear medicine imaging can use to distinguish accurately presence of the leak. So in this case, as we can see, as the image passes, we can see there is a abnormal tracer uptake being secreted outside of the normal hepatobiliary system. And this accumulation of radio tracer become more and more intense as the study progresses. And this confirms that there is presence of a biliary leak. Okay, right. Next scans will be the one for Merkel's diverticulum. This is actually a gold standard to identify Merkel's diverticulum. Usually it's in the pediatric setting, but adult also we can also do this in adult. So what happens is when we inject a radio tracer, and we'll start seeing an accumulation, a focal accumulation in the right inguinal region. So when we have a focal accumulation like this confirms that there is a presence of a Merkel's diverticulum. All right, so next scan involving the kidney. Now, kidney, we have a few radio tracers. So the indication would be in case if you wanted to assess for a renal function, right? So in this case, what happens is that patient had Stacon calculi. This image is taken posteriorly. So the one which I'm pointing with my arrow is going to be your left kidney, and the right kidney is going to be on the side. So what happens when this patient noted to have a Stacon calculi, and because of this Stacon calculi, they need to assess whether the kidney is actually functioning or not. Is it worthwhile doing an intervention or not? So the primary team usually will refer to us. We will do a scan. So by doing a scan, we can clearly, distinctly tell them that the left kidney is actually functioning, whereas the left kidney is not visualized at all. So this indicates this is only a single functioning kidney. The right is not at all functioning. And apart from that, what we can do is we can also tell you the relative function of both kidneys, how much function is being carried out on the right side of the kidney and how much of the function is on the left side. That kind of information we can actually give. We also do a GFR study for patient, the donor for a kidney transplant. So we can send that send the patient to us. And we can also assess the function of the kidney after the transplant. I did not put the image here. After transplant, in case if you wanted to assess for any function, yes, we can do. In case if you wanted to assess for any complication post-transplant like urinary leak and so on, yes, you can send it to us. We can assess that. Apart from that, we can also assess presence of renal obstruction. So for example, in this case, this is the right side. I'm being pointing with my pointer, and there's a left side of the kidney. So what happens is on the left side of the kidney, this is the normal sized and normal functioning kidney. Whereas on the right-hand side, as you can see, it's slightly enlarged. This is a hydronephrotic kidney. And in terms of uptake, of course, the left side seems to have a better uptake compared to the left. So the function, it tells us the function on the right is reduced. And when the images, as this images progresses, what we can see is that on the left side, it is being from the kidney, it is slowly being excreted into the pelvic helisal region and slowly being excreted down to the bladder. Whereas on the right side of the kidney, it kept on accumulating the radio tracer, it becoming more and more and more darker until the end of study without any evidence of excretion. So when we do a time activity curve, we will plot the graph like this, and you can see on the left hand side, this graph is denoting the left kidney. So it goes up very well as we give the radio tracer, and once it reaches the peak, it falls down very well. So it's being washed out beautifully. Whereas on the right hand side, the tracer accumulation is given, but instead of coming down, it kept on accumulating upwards. So this is an example of a proven obstructed kidney. All right, and we can also do a relative calculation by telling what is the function of each kidney. So the left-hand side shows is doing more function. The normal should be somewhere about 55 to 45. Because the right kidney's function is being reduced, the left kidney is working a little bit harder. Okay, so these are the informations that we can give to the referring team. All right, apart from that, we also have a renal scan known as a DMSA. It's a dimercaptosuccinic acid. So this radiopharmaceutical, when we inject, we can assess whether there is a cortical scarring. It's a cortical imaging. So on the left side of yours, this is a normal kidney. We can see there is a very smooth, beautifully distributed cortex. Okay, but on the left-hand side, what happens is there is a photopenic area can be seen around this region, and this indicates scarring has already taken place. And this kind of scan can be done in a patient who has been having a recurrent UTI, who has a pyelonephritis, or having a VUR, the psychouretic reflux, and this kind of patient are prone to have a healing and fibrosis can take place. So if you want us to assess on this, yes, we can do an assessment by using a DMSA scan. Right. Next, we also offer lymphoscintigraphy to assess the patency of the lymphatic channels. So this lymphatic channel, we can assess both the lower limb as well as the upper limb. So for example, I'm giving an example of the lower limb injection. So let's look at the normal study first. So what are we going to do is we're going to take the radio tracer, we're going to inject in the bilateral lower limb, exactly in between the big toes and the second toes. So once we inject, we can estimate it's supposed to be migrating beautifully upwards into the inguinal lymph nodes, into the iliac, and eventually into the abdominal lymph nodes. So this is actually a normal lymphatic vessel. But in a case where we suspect there is an anomaly, it could be a primary lymph edema or a secondary lymph edema, we can do this imaging. So again, when we inject, so this is an example, the first on the left-hand side, when we do a tracer injection on the right-hand side, this is a delayed image, hence the tracer flow is already gone up on the right-hand side. So you can see the inguinal and the pelvic lymph nodes here. So on the right-hand side is actually a normal lymphatic channel. But on the left-hand side, when we inject, there's a lot of dermal backflow. The vessels are actually dilated, it's tortuous, and there's a lot of dermal backflow, which confirms that the patency of lymphatic vessels it's reduced. Okay, the valve is not functioning well, hence it's causing a lymph edema. The example on your right-hand side, otherwise, when we do injection at bilateral lower limb, on the right-hand side, what happens? The radiotracer only managed to go up to the level of ankle. Anything that is above the ankle, the radiotracer is not migrating up. And this indicates there is a complete lymphatic obstruction. Worse, on the left-hand side. So the tracer, once injected, has been remained at the level of foot. So in here, we can tell the severity and how bad the lymphatic obstruction is taking place. Okay, so any causes, primary or secondary causes, we can do the assessment, both upper and also lower limb. Right. Next, we do offer a syntimmum. Syntimmum stands for technetium, which is being labeled with a bacillosomab. This syntimmum is actually a monoclonal antibody. We will be injecting this monoclonal antibody to the patient, and which this monoclonal antibody has a very high affinity towards NCA95 antigen. And this antigen are commonly being seen expressed a lot in an inflammatory or the infectious lesion. So for syntimmum, not all patient, we will subject the patient for a syntimmum. This comes under the description of a nuclear medicine physician, because in case if patient already develop an antibody towards this antigen, anaphylactic reaction can take place. And let's say we introduce this radiotracer into the patient, it can be only done once in a lifetime. And this radiotracer is reserved for certain indications, but you can always have a discussion on this. I'm not going to go very much in detail. Okay, maybe a little bit. The reason why we use a syntimmum for this patient is this patient had a history of fracture of the right femur, mid-right femur. So when he had a fracture, it is healed in a malunion. There's a malunion have taken place. Whenever there is a malunion, if we were to assess infection by using a bone scan, so the process with the malunion, the bone remodeling process will be ongoing for many years. So bone scan will take up, even though there is a bone remodeling, the radiotracer is going to take up. So we won't be able to distinguish whether the uptake is due to a bone remodeling, or is it because of infection. Whereas when we introduce a syntimmum is very specific for infection. So in this case, the uptake that we see in the right mid femur, it is actually a case of an infection. It's an underlying osteomyelitis. Okay, so syntimmum will be done at a discretion, under nuclear medicine discretion. Right, so subsequent scan that we can do is a cardiac scan. Now, cardiac scan, this topic is actually a whole topic by itself. So I'm just going to summarize what we can do at the moment with this cardiac scan. Right. So cardiac scan, we will do a 2 days protocol whereby the first image will be taken during a stress study, and the bottom row of the image will be done during the rest study. Okay, this image is taken via different axes. Okay, so I'm just to summarize this for a better understanding, the first image is going to be your stress image, and the bottom image is our rest image. So when we put a patient under stress, what happens is, has been pointed by the arrow, there is no blood flow seen in the septal region, the apicoseptal region. So there's no flow, and there's no flow in a few cuts. But however, when we make the patient rest, what happens is the perfusion is actually improved. So this is an indication that there is an undergoing ischemia in the distal LAD territory. Okay, so this is how we will pick up there is a presence of ischemia in that particular blood vessel or territory. Okay, now what happens with this patient is that when we inject a radiotracer during a stress, there is a reduced perfusion, a fixed defect perfusion. There's a perfusion defect over here on the septal region. When we rest the patient again, the perfusion defect persists, and this is actually an indication of infarction has already taken place comparatively to the normal images that I put side by side. Okay, so these are the two things that we can actually tell you out. There's a presence of ischemia, there's a presence of infarction. Nevertheless, that we have plenty more cardiac scan that we can do, which in future, if we have time, we can discuss in another session. All right, apart from that, we also do offer cardiac scan known as this cardiac amyloidosis scan. And this scan is very specific for the transthyretin type, the ATTR type. So we have two, right? Cardiac for amyloidosis, the light chain, and also the transthyretin type. So this one is very specific. So when you suspect a patient to have a transthyretin type of cardiac amyloidosis, feel free to send it to us. We can introduce a pyrophosphate, a technetium labeled with a pyrophosphate, we will inject to the patient. So when we do an injection, if there is none, we won't see any uptake in the cardiac. Okay, but if there is an uptake in the cardiac as compared to the other side of the tissue, means that there is a present. We can assess qualitatively as well as quantitatively. So what we will do is we will draw a region of interest here. We will draw on the heart, and we'll draw another region of interest in the contralateral lung, and we will look for the ratio. So if the ratio is more than 1.5, means there is a positive involvement of cardiac amyloidosis for this patient. Okay, right. Apart from that, we also offer a whole body iodine 131 scan to assess presence of a residual or a metastatic lesion for those who have undergone a total thyroidectomy for a malignant lesion. Okay, so in this case, patient has already undergone a total thyroidectomy, HPE proven to be a well-differentiated thyroid. We will give a therapy and we will do a whole body scan. So the black, very intense hexagonal shape features that we are seeing here denotes that there is a presence of a residual diseases in the patient. So once the therapy is being given, we will do a reassessment. And in this reassessment, whatever uptake that we see in the neck region is no longer there. So it shows a very good response to the therapy. And don't worry, the uptake that you see in the stomach, this is a physiological uptake of tracer, that's fine. And that's physiological uptake of tracer in the bladder. Okay, apart from that, we also have what we call as tract cryoscintigraphy. I'm not so sure how tract cryoscintigraphy is helpful for medical department, but if there is a cases where you suspect there is an obstruction at the nasolacrimal gland, if patient is keep on having a persistent eye, watery eye, usually it's supposed to be under optal, but in case if there is any patient that you would like to assess, you could send it to us. So what we can do is we will take a drop, an eye drop, make it the radioactive material, we'll make it in terms of a drop, we will drop in the eye. So in this case, we have already dropped in the right eye and also in the left eye. So the minute after we drop, we will do a serial of dynamic imaging, and the nasolacrimal duct on the left-hand side is so patent, very good flow up to the nasolacrimal region, the nasal region. So it's a good flow. Whereas until the end of the study, there's a persistent accumulation of tracer on the left-hand side. So that denotes there's a presence of a obstruction at the nasolacrimal gland. Right, so these are the scans that we can do. Well, and we also have an upcoming scan known as the iodine 131 tagged with MIBG for a neuroendocrine tumor. So we'll be doing the scan very, very soon. Right, in terms of scan, so whatever that I've described is actually only a small part of service that's being offered by at Sabah Center, but actually, indeed, we actually have plenty more scans. I'm discussing what is available at the moment here first, okay? Right, in terms of therapy, of course, we have varieties of therapy, and most of these therapies are done in Semenanjung site. But in Sabah site, as for now, we have three types of therapy. One, utilizing the iodine 131. We are using a very high dose for a well-differentiated thyroid cancer. Okay, the second will be the iodine 131 therapy, which is a low dose to treat for a hypothyroidism. And we also have a radiosynovectomy to treat for joint synovitis. And the indications for radiosynovectomy is in case if patient is having this CP, PD arthritis, hemophilia, any inflammatory joint diseases, persistent synovial effusion, after joint prosthesis, and this pigmented velonodular synovitis, rheumatoid arthritis, spondyloarthritis, and any other undifferentiated type of arthritis. And usually this radiosynovectomy will be done after a thorough discussion between both teams. And once the medical treatment or the surgical treatment are no longer being beneficial for the patient, and yes, we can introduce this radioactive material intra-articularly to treat this condition. Okay, so I think that's all for today's CME. May I ask if there's any question that I could help? So don't worry about sending if you're not so sure whether these cases can be sent for nuclear medicine imaging, you can always, please be free to call us anytime. We are more than happy to help, to guide through for the benefit of both the department and also for the patient. So, and off note, we are getting good news is that we are getting a SPECT-CT machine, the hybrid machine that I talked about earlier. So installation, renovation will be taking place hopefully somewhere in July, I hope, onwards. So we will have a temporary cessation of services until it is fully remodeled. I think that's all from my side. Is there anything else I can assist?
Okay, thank you so much, Dr. Piria, for that very comprehensive introduction to the services at the Nuclear Medicine Department. I think we have a few questions. Anyone who wants to ask questions, you can ask in the chat box. Okay, I think Dr. Gordon is asking. Dr. Piria, I will just read out the questions if you don't mind, and then you can answer convenient. So, DAT and PET scan on the horizon as well.
Okay, so DAT scan is mainly used to assess the dopaminergic nervous system. So we can actually do this DAT scan by just using a normal gamma camera. Okay, so for the PET scan, we have a list of indication for a brain imaging. So at this junction, we hope to start the services in future. So for DAT scan, no issues. I think in future, once we get this hybrid imaging, we can start the services to look at the dopaminergic sites. Right. Did I answer your question? Gordon Tang.
Yes, thank you. Good to hear that. So that means there will be some hope for alpha-synuclein disease and also.
Yes.
So the functional PET for brain imaging, right? Would that be happening anytime soon?
Anytime soon. Okay. It may not happen anytime soon because we have to draft right from the scratch. Number one, and number two. We will try our best. We shall update you. I shall discuss with this with Dr. Chan Kwat Chu. She's also there. We will try our best to make it available.
Thank you so much.
But it's not happening anytime soon because the PET scan, the process of PET scan is actually ongoing. So we can roughly estimate about a year or two, maybe. But surely, hopefully we will start the services. It will be very, very beneficial for neurologists.
Okay, thank you, Dr. Priya. There's another question from the team that we have patients with IPTH given after total parathyroidectomy. How can we go about doing a scintigraphy?
Oh, actually, you can just drop a request form giving a full history of the patient and just email us the request form, and from there we will do the scan. So it is not complicated. So in order to communicate, I think you can always call our MO or just drop an email with the request form. Yeah.
So in addition to that, Dr. Pira, say if we are uncertain about indication or we will think that okay to discuss the possibility scan.
I'm so sorry, you're breaking. I couldn't catch what were you saying. Could you repeat?
Oh, sorry. Okay, is it clearer now?
Yeah.
Okay, so just turn off my. So for instance, if we have some cases which we feel might benefit from nuclear imaging,
Yeah.
and but we are, I mean, because this is not a very familiar field for many of us, and if we would like to have a discussion first before making a formal request, is there a way for us to do that? Who do we contact?
Oh, you have no problem. You can always contact us, that's the physicians, or you can always contact our MO. No problem. Don't worry about that.
Okay.
We're always willing to help out.
All right. I have a question of interest. I was very interested in the Centinium scan that you mentioned that is good for picking up very sensitive towards infection.
Okay.
So in the medical department, we sometimes encounter patients which we have after history taking examination and other imagings that we do not know where the source of the infection is.
Mm-hmm.
Do you think these kind of patients might benefit from that Centinium scan that you mentioned about? But it's only a once in a lifetime, right? Means they do it once and they can't do it ever again.
Yes, that's right. That's right. Okay, so we have to go case by case basis. If let's say we have to go case by case basis. If let's say the infections, okay, let's say the clinical suspicion. Where is your clinical suspicion of infection? In organs, you say? You mean? If it's no problem. If it's involving other organs, in order to identify a focus of infection, I think another method of doing would be a PET scan. Centimum per se, in order to identify in organs, centimum usually goes to the bone. Okay, and inflammatory cell, of course, yes, septic foci, but we have to go case by case basis. Can you give me an example so I can
example? So
perhaps
there are some patients.
Perhaps in the liver.
Yeah, perhaps in the liver or some patients. A lot of times we sort of label them as a caught sepsis, and that means we don't know where the source is, and after normal X-rays, ultrasounds, and when we can't find a clear source, and they could have some bacteremia, for example.
Yeah, we can consider doing that. Yes, we can consider doing that. Yeah.
Okay.
In future, when we have a PET scan, if you have any occult type of infection, I think it would be best to be done with the scan.
PET scan. Okay.
So that would be in future, but for time being, if there is any occult, you cannot find the source of infection, you have already come to a dead point, always call us. We will see if we can help out.
Okay. Thank you, Dr. Pira.
Okay. All right.
Okay. I think Dr. Liu has a question.
Yeah, hello. Hi, Dr. Priya. I'm Dr. Liu, a cardiologist. Good to see you, and thanks for the talk.
Good to see you too.
Yeah, just on the discussion about infection, the suspicion for endocarditis, and occasionally, patient with implants, patient who have, let's say, a pacemaker.
Okay.
We suspect infection. Do you have much experience? How you
usually, yeah. So usually what happens is whenever there is an infection of the implant, the best way to go is doing a PET scan. The best way to go to assess for an implant. I actually do have several images that involving infections in the implant. Maybe one of these days when you guys are free, I can show some of the images that we have done in IJN. So the best way to go is, I still feel it's a PET scan. we can absolutely pick up all these infections, endocarditis and pacemaker implant infection. PET scan is the way to go.
Okay, thank you. So we don't do the radio label white blood cell scan anymore?
It's not we do not know, we do not do. We can actually do what WBC scan, but it's actually a very tedious process, and whereby we need a proper lab setup. We do not have a proper lab setup anywhere back in West Malaysia or here. So
a setup for preparing the radio the radio isotope, or
yes. We need a multiple multiple lab technologies to be involved, a proper lab equipments to be involved. But instead of doing with WBC scan, we can always do with a PET scan, because PET scan equally have a very high sensitivity in picking up all these infection-based lesions. So
and the
specificity is also very high.
Okay.
Yeah.
All
so
right.
I think that's the limitation factors that we are having at Sabah. We do not have a PET scan. Otherwise, we can extensively do a lot of imaging for cardiac. We can do for cardiac sarcoidosis. We can do for infection inflammation. We can do a viability scan. We can do a perfusion imaging. Yeah, it's for hypernating myocardium. Yeah, we can do all that. Once the PET scan is up, we will set up all the services.
Okay. Thank you for the information.
Thank you so much. Thank you so much.
Thank you so much, Dr. Pira, for the answers and responses. Anyone else has any other questions from the floor? I think our head of department, Dato' Rahman, is in attendance as well. I'd like to say something.
Okay, sure.
Okay, I think maybe he might be away. Right. I think there are no more questions from the chat box. Again, I would like to thank...
do we still have time?
Yeah, Dr. Liu, you wanted to...
Yeah, if we, I don't know whether we still have much time, but if we have time, it would be good to hear from you. What is the current setup for services in the nuclear medicine department? What's a typical week, for instance? You know, what sort of services you run? Are there any specific things that you do on each day, you know, Monday to Friday?
Oh yeah. We do. Usually, what happens is we have to specify which scan is being done on which day. The reason being is because we have to do a tagging. So let's say we accumulate all the patient together. We need to open up the vial, and once we open up the vial, it is wise to use for about 10 to 12 patients at a go. If we do not accumulate the patient, what happens is each of this radiopharmaceutical vial is very expensive. It costs thousands of ringgit. Okay, so for example, like Monday, we can do a bone scan, and then we also sometimes we do 2 scans at one row. Bone scans, we will do a thyroid scan. The following day, we might accumulate all the renal scan in one go. The upcoming days, we might do a cardiac scan. So it depends. We have to one scan. One type of scan for one day, because of the tagging. The process need to be done that way. Unlike radiology department, if let's say urgently you need to put a CT scan, what happens is you can do, because you do not need to involve this radiopharmaceutical. But unlike for us, we have to tailor in a day how many patients need to be done. Once we do an elution of the radiopharmaceutical, we can only elute to certain amount, and we are also bound to decay. So if we add more than what the medicine can be produced in a daily basis, then it's going to be a waste. Okay, so it has to be tailored according to how many number of patients, the availability of how many MCI of a radioactivity available for that particular day. That's how we will do the imaging.
Yeah, I think that sort of introduction is also very important. Of course, as what our chairperson Josia said, many people may have no exposure about nuclear medicine at all to understand these things. So currently, if I may ask, what are the top 5 indications that you receive for nuclear medicine service? What are the top 5, and how are you providing that service?
Actually, we have plenty of indications are coming in. There's no such thing as top 5, top 10.
Okay.
Okay, whatever indications that they are being asked for us, we will accommodate accordingly. Okay, it doesn't matter from head to toe. For time being, perhaps the one thing that we are not doing at the moment is a brain scintigraphy, because brain scintigraphy requires a special training for it. So far, we only have one who done a special training in the brain, Dr. Kamalia. She's no longer at Sabah, she's back to HKL. We need more trainees in that. Number one, that is our limitation. It's an emerging and evolving field. Other than that, of course, the PET-CT we are not doing extensively here, and also therapy. Therapy is the one which is lacking actually.
Yeah, so those are the ones that are important, but we don't have yet. But what are the ones that we have at the moment? What is the one that keep you busy most?
Sorry?
Bone scans, what are the most things that you get for? Cancer, bone scan, diagnostics. What is it?
Get for everything actually.
Dr. Liew, sorry for interrupting. I'm Dr. Chan. I'm Priya colleague actually.
Hi.
So Dr. Liew, actually, both of us are trained in Penang Hospital, and I've been in HKL for a while also. And actually, our MPI cardiac scan will be taking up around 50% of the nuclear medicine imaging for SPECT and SPECT-CT. But for in Sabah, I don't know for what reason, I seldom receive cardiac MPI, myocardial scintigraphy, which just now about to rule out ischemic heart disease, diagnostic exclusion, and also for to see how severe is it the ischemic changes that require invasive angiography. As I know in US, if you want to claim insurance coverage before you go for an angio, they require you to do an MPI, but it is not Malaysia. So for Sabah, how is it go about for let's say patient has a chest pain and atypical ECGs show some changes. I work in HKL before, general medical clinic. Usually we will also go for all these diagnostic tests because we don't have a cardiologist there. But I think things would be different because Sabah has a cardiologist. So may I know how is it go about in Sabah?
Well, I think you have the answer. Depends on the service that you have. I think the evaluation of chest pain, or if you suspect coronary artery disease, the approach to investigation include stress testing for provocation. So we can look at ECG changes. And some of these cases, we may do a stress plus imaging. So the stress plus imaging include stress echocardiography, or stress MRI, or stress nuclear scan, and now even emerging stress CT scans. What we have available in Sabah here is stress testing with stress echo. And in some of the cases where the probability is high, we cut the chase. We offer coronary angiography. We get the coronary, what is it? What I call it, the imaging. So, we don't do a lot of CT here because we don't have, a full-time radiologist or cardiologist who do cardiac imaging as a subspecialty. But in some services and some KKM center, they have that. So some of the intermediate risk group where the pretest probability is intermediate, the CT scan is another option. So I think if we look at the landscape for coronary artery disease investigation, as in for patients who have suspicious disease, the landscape in Malaysia is majority would be stress tests, followed by CT scan. In the private hospital, especially, a lot of CT scan now are being done. even without the stress test sometimes. So that's the situation.
Thank you, Dr. Liu. For us, I think we can offer MPI if required. You can send patient for myocardial perfusion imaging. That's another options, non-invasive before go for angio.
Yeah, well, I'm not sure whether I'm going to take up too much of the time, how much time in this session. We should have another meeting to discuss about the strategy. 10 years ago, we had a discussion with a nuclear medicine physician, and even State Pengarah was involved as well. And we were talking about, if there was only one nuclear medicine specialist at that time, now there are two of you. If let's say you only have one nuclear medicine physician, you only have one machine, you've got limited resources. What are the most important service in need, in the state? And do you have the manpower to provide everything? So it's different when you are in a mature center where you have a team of nuclear medicine physicians, then you can explore doing things ABC, beyond ABC, DEF, and so on. But let's say if you're one person handling a state and looking after this, you might have a lot of critical need from certain things, and you're going to focus in those first. I'm not sure. That's why I asked about your burden. Maybe there's so much a request, for cancer scans and so on. And I wouldn't want to have a cancer patients that you have to have a long wait, for a scan, while you dedicate 1 out of your 5 days, to do, a service which may not be critical, like say cardiac scans. So that's just a strategic way of looking at service planning. Everyone has limited time. You only 5 working days in a week, unless you really work all the time, 365 days. And last time when there was only one nuclear medicine, we always say, if the person goes on leave, what happened to the critical service? Who would cover?
Thank you, Dr. Liu. Maybe we shall not take up so much time here. One day I can meet you in person and we talk about that.
Oh, lovely.
Thank you, Dr. Liu.
Look forward to meet you. Bye-bye.
Right.
Right. Thank you, Dr. Liu and Dr. Chan for the discussion. I think it was of very much interest to the medical team as well, although we are in a separate hospital, because we frequently encounter a lot of patients with ischemic heart disease, with heart failure. So perhaps, because we know also that the angiography list is very long and sometimes patients have long waiting time. Perhaps an MPI might help stratify and decide which patients might need to go, need a bit of priority for intervention, or if they are suitable candidates for intervention. Okay. So I think we've come, well, it's about 4:30 now. So from the medical department, we'd like to thank our nuclear medicine physicians, Dr. Piria and Dr. Chan, for your time and for sharing with us the services that are available at the nuclear medicine department at the hospital with us. We hope that we will be able to, to get in touch with your team more and do the best for our patients. All right, so if anyone has any other questions or referrals to make, I think our nuclear medicine team will be happy to have a discussion with any of us here. Okay.
Right. Okay, thank you so much for the invitation. We are so happy to be part of medical team. Please do feel free to contact us if anything needed. And likewise, I hope that we too can join some of your medical department talks or CME. That would be great.
Yep, Dr. Piria, sure. We will keep in touch and we'll see how to work together in the future.
All right.
Definitely, yeah, we're certainly welcome to join our department CME as well. We're looking at expanding our capacity, so we will let your team know as well. Okay, so the attendance will be posted for those who are attending. Thank you for staying to the end. We will post in your respective groups. And just a quick announcement here from the department. for the medical department, we are having some movements of the wards and the relabeling of our ward locations. So the current GenMed 3 in the 8th floor is now in 7th floor, right? And it will be GenMed 1. So basically 7th floor will have GenMed 1, and then 8th floor GenMed ward will be GenMed 3. GenMed 2 will be at the back half of rehab ward until ISO 2 at level 7 is ready. Right, so a brief overview of the general medical wards. 4th floor will have AIM 28 beds. 7th floor will be GenMed 1, 32 beds with PAL and ISO ward and ISO 2. Then the 8th floor will be GenMed 2, the rehab site for 10 beds, and GenMed 3 will have 32 beds. We also have the ID ward uphill opposite the canteen that will open this week with 20 beds, 9 female, 11 males. And also a chronic medical ward uphill, 16 beds. Okay, and other announcements from Medical Society, we are volunteers, committee members for our upcoming medical update. It will be tentatively in August, and also a medical night. Those are interested. And SP update is coming up on 7 to 8 July. Those are interested, sign. All right, so thank you very much for your time. I will post up the nuclear medicine referral in your group as well, so that you will get in touch with them.
Very sorry for interrupting again.
Yeah, sure, no problem, Dr. Chan.
Actually, our service will be like Dr. Priya mentioned just now. Mid of July, I will stop taking in any referral because of we are upgrading to the SPECT CT, which we can do a CT component on it, a hybrid scan. So maybe we will reopen on starting of November. So we will take in referrals starting of November.
All right. So basically, referrals will be on hold from now till November. Is that right?
Mid of July. If you got any urgent case, you can still cater to it till mid of July. Yeah.
Okay.
Thank you. Thank you.
Noted, Dr. Chan. All right. So thank you, Nuclear Medicine team, Dr. Priya and Dr. Chan. And, so we will end the session here. Thank you very much, and you all have a good day.